welcome guys. Thank you all so much for joining us. Today's session is just a 45-minute session on frozen shoulder and what the current evidence is around assessment and management in primary care. So just for those of you who've not joined us before, just to let you know that this is just a peer support space in order to share best practice opinions and resources. Please feel free to contribute any kind of knowledge or experience you have in this area with the group. We'll be really welcome to your knowledge and any information that you can share. Please ask any questions. Obviously, it's just a space where we'll treat anybody with respect and kindness. So if this is an area of the body or a condition that you don't know much about, please feel free to ask any questions. And we'll monitor the chat box. So, you know, you can unmute and ask a question or pop anything in the chat box if that works better for you. So just to recap on us, Desi and I are the AHP as ambassadors for primary care, working for the Nottinghamshire Alliance Training Hub. We are both physiotherapists by background, although Desi also is a clinical lead for the occupational therapy group. So she kind of wears two hats. So nice to meet you, anybody who's joining us for the first time. So the objectives today are just to present the current literature, a little bit about the pathophysiology of frozen shoulder and then the assessment and the management. We just wanted to link it to primary care, to discuss the Nottinghamshire pathways, and then at the end just to signpost you in the direction of how you guys can get support from NATH with any kind of literature searches or questions that you might have. So firstly, what is frozen shoulder? So it's an insidious and progressive severe restriction of both the active and passive shoulder range of movement in the absence of a other disorder of the shoulder. So it's thought to be self-limiting in that it normally gets better by itself within 18 to 24 months if it's left. However, this is rarely the case because it can be so painful in the initial stages that people really struggle to cope with that pain. Some patients actually have the residual pain and the stiffness in the shoulder, which can last several years beyond this kind of expected 2-year time frame. The exact pathophysiology of it is unknown. There's one theory which suggests it's all to do with fibroblastic proliferation, so very much similar to a Dupuytren's contracture that you might see in the hand. And then there's another theory which suggests that it's both inflammatory and fibrosing condition. So kind of the current research is thinking that there's this combined impact on the joint health. So there are 3 phases to a frozen shoulder. So lots of people will present in primary care in this initial phase, which is the freezing phase or the painful phase. So this is thought to last between kind of 2 and 9 months. And at this point, the pain kind of starts to increase. It's often constant and it's often very painful at night. At this point on arthroscopy, you can see that there's kind of very aggressive synovitis. So this is thought to be the inflammatory stage of the condition, which is why we're going to talk about use of injections a little bit later in the presentation. So use of injections tends to be most helpful in this phase, in this early freezing or painful phase. The next phase is referred to as the frozen phase, and this can last sort of from 4 months to 12 months. And this is generally the stiff phase. So by this point, the pain tends to have settled a little bit. We tend to find perhaps less night pain at this time, and people less reliant on pain relief. And actually, normally they just get some pain at end of their kind of range of movement. So more sort of pain on challenging functional activities rather than that constant pain. And at this point on arthroscopies, you tend to see that the synovial inflammatory reactions reduced, but actually at this point you can see the capsule and the ligament have started to fibrose, which is why you get that kind of real loss of shoulder range of movement. And then the thawing phase is the positive phase. This tends to last between 12 and 42 months. And at this point, there's a gradual improvement in range of movement. So the stiffness starts to resolve. And again, at this point on arthroscopy, you tend to see that fibrosis starts to kind of recede, and the shoulders, the soft tissue surrounding the shoulder joint starts to look kind of more healthy again. So you can refer to them as the freezing, the frozen, and the thawing phases, or they can just be considered as a pain predominant phase, which is the initial phase, a stiffness predominant phase, that second phase, and then kind of the recovery phase, which is that third phase. So who gets a frozen shoulder? So it tends to affect between 2 to 5% of the population. It's most common between the ages of 40 and 70, and the prevalence in women tends to be just that little bit higher. Risk factors for developing it includes a history of a traumatic shoulder injury. So we see quite a lot of people that have perhaps had a fall onto an outstretched arm and then present a couple of months later with a really, really painful shoulder, which is beginning to look stiff. Anybody who's had any prior surgery on that shoulder, so your kind of subacromial decompressions, your rotator cuff repairs, they're all at risk of developing a frozen shoulder later down the line. 25% of all of the cases of frozen shoulders occur in diabetics, and 5 to 10% of all of the cases of frozen shoulder happen in people with thyroid issues, and that can be hyper or hypothyroidism. And the bad news for people with frozen shoulder is that if you've had it on one side, 20 to 30% of people who've had it on one side will get symptoms on the other side at some point. So yeah, again, we're not exactly sure why, but there's just these certain groups of people who are prone to it. And yeah, a third of the people who get it on one side will go on to develop it on the other side. I am going to pass over to Desi for the assessment section.
Hello. So as we all know, most of the time you'll get a good idea of what we're looking at just by the subjective, but obviously looking at some of the objective markers. So depending on the phase, as Laura said, is if it's going to be more pain or stiffness, or if you're going to be able to assess range because of pain to actually identify, is it stiff or is it that is the pain that's the issue. So the most common rule of thumb is that active and passive range are the same, whereas if you're looking at more, say, rotator cuff issues, that's where actively they might get to 90, but when you passively move it, they can get all the way. That's very unlikely that it's going to be a frozen shoulder, and if it is, it's a very early phase. Whereas your more classic frozen shoulders is they get to 90, you passively have almost like a stiffness block in that respect. So external rotation is also a big one. So you can have a look at flexion, but external rotation, if they got it actively and if you try passively. Generally, again, a high sensitivity of pain over the coracoid, and then having a look at other provocative tests. But obviously we know with shoulders, they haven't got a very high sensitivity when we're looking at things like the Sperlings and the Hawkins, and like ruling out with neck. But most of the time it's having a look at that history, and especially with those differentials. So if you don't mind going to the next slide for me. So differentials, it's obviously what is the history, as Laura said. Is there any other comorbidities? Have there been previous trauma? Have they had a frozen shoulder before? What is the pattern of pain? Is there any other referral patterns? Is there any neural symptoms, any neck symptoms? So the biggest thing with these is making sure we rule out all the nasties, and especially making sure there's not a lung or more sinister pathology going on. Next slide. So this is what the best, so the British Elbow and Shoulder Society guidelines. So it's quite a nice little flow chart that you can have in your clinic, and it's looking at more general shoulder pathology. So if the pain is here, like doing this test, what is it likely to be? And it has a nice quiet flow chart. It obviously says about location of pain. So with frozen shoulder, it's unlikely you're going to get symptoms that go down the arm. Making sure that you are ruling out those red flags. That's always kind of the key part. If we've got stiffness, why can't we move in that range? So is it the capsule, or is it that we've got a space occupying lesion? So I said it's on online, or when you get the presentation, it's got the link. So if that's a poster you want to print for your clinics. Next slide, please. So poll time. So I'm feeling very high tech. So we're going to do a poll. So you've got a patient in your clinic. Are you going to investigate? So are you going to MRI, ultrasound, or nil? So we've got no. Oh, there we go. So you should see it in the chat. And just tick away, what would you normally do? So you're considering it's frozen shoulder. That's your current. Of between X-ray and nil. Give that one more minute, and then ultrasound. We can have written as well. And appreciate I'm a little bit ahead of time, but if you were to inject, do you X-ray beforehand? So second poll. For an injector, or if you're going to refer to an injection clinic, so it's not like you have to do it, but what is your opinion? Would you do an X-ray before you do a steroid injection? So this is their first steroid injection for this first presentation. Ooh, one each. So at the minute, we've got for X-ray 42%, ultrasound 14, and nil. So it's biased towards X-ray and not at all. And we're a bit more even Stevens on injection. So if we can go to the next slide, please. So obviously I've already given away the main three investigations. So obviously with X-ray, that would be the more preferred initial test. So it's having a look if there's any other structures. So is it those OA changes? Is there any kind of osseous changes, potential space occupying lesion, or any other pathology that might be a cause? Obviously, if we're looking at the capsule, this won't show anything about the capsule. That's where we can have a look at the ultrasound if there is thickening of the coracohumeral ligament. However, we have to think about where they are in that phase. So we talked about the freezing, the frozen, the thawing on arthroscopy, but obviously it's how reliable that's going to be an ultrasound and being very aware of what phase you're in. So it's how much information is that really going to give you, and will it change your management? MRI, again, how easy is it for us to get MRIs in primary care, and if you can order in primary care, depending where you're based. But if anything, it's more to rule out other structures as opposed to rule in that it's frozen shoulder. So we go on the next slide. So this is the Nottinghamshire Radiology Guidelines. So for a non-specialist, so this is GPs, AMPs, paramedics, basically not specialist MSKs, either secondary care, your MSK interface, or your FCP physios might have privileges to do specialist MSK investigations. But this is where for X-ray, the reason you're doing it is to rule out another pathology. So is it OA is the cause, as opposed to ultrasound? They say no for frozen shoulder, because again, will it change your management? And obviously MRI, it's no, it would have to go to a secondary care because we're looking at other structures. So if we, next slide. So when we look at the MSK specialists, as I said, we do include MSK FCPs. They don't actually have like a frozen shoulder, but I added in the painful shoulder. So obviously that's when we look at frozen shoulder, they're normally complaining of pain. And again, it's more looking at those bony characteristics, as opposed to ruling out the nasties. Okay, and then it obviously says about MRI, but that would go to your MSK interface, because I know in Mid and South, or Laura, correct me if I'm wrong, in South Notts we can't order MRI shoulders. Can you in Mid?
No,
No.
shoulder
So
MRI.
if you're looking at that, send it to your interface as soon as possible. Next slide. Hand over to Laura.
So in terms of the current guidelines, the first line of treatment is thought to be around activity modification and physiotherapy. So initially, people should be advised to avoid exacerbating activities to try and kind of stop that ongoing cycle of inflammation. So they tend to be things like reaching above 90 degrees, internal and external activity, rotation activities. So things like putting on a coat, popping your hand behind your back to tuck in a blouse or do up a bra, you know, they tend to be the things that are really are very painful for the patients. And in this early phase, pain control is key. So it's thought that if you can get the pain under control and you can get people moving the shoulder in that painful first freezing stage, the progression of the disease is less severe than for people whose pain is kind of out of control in those early phases. It's thought that physiotherapy is the cornerstone of successful treatment of adhesive capsulitis, and that we should start it as soon as possible in the disease course. This is something that has changed. I think 5 years ago I worked in a physiotherapy service in London where we didn't accept frozen shoulders because at that time the evidence around physiotherapy for the treatment of frozen shoulder wasn't strong enough, and so they tended to be managed in primary care, kind of with pain relief and injections, and then sent through to orthopedics if the symptoms weren't improving. However, the evidence now for the use of physiotherapy is much stronger, and that kind of initial referral at an early stage into physiotherapy is known to be helpful. So patients should be doing exercises at home, which consist of both them actively and passively moving the shoulder. So on Amazon, you can buy shoulder pulleys that for about £10 or £15 that hook over a door, which you pull down with your good arm and can help to lift the other arm. So things like that work really well for some patients. There's also the possibility to use kind of sticks and things to try and kind of get some abduction and some external rotation. But also that it is helpful if people are having that kind of formal supervised outpatient therapy, as long as their pain is under control. So there's some preliminary findings from a systematic review to show that kind of mobilization techniques on the shoulder can be helpful. So manual therapy can have some beneficial effects. So manual therapy isn't really something that will be offered in an NHS physiotherapy department, just because they don't have the kind of the time or the frequency of appointments to be able to provide it. But for those patients who say, you know, I see a chiropractor, should I continue to see them, or should I, you know, pay privately for some treatment? There is some evidence to show that having manual therapy on the shoulder will be helpful. And we should ask patients to start the sleeper stretch. So the sleeper stretch is a stretch whereby you would lie on your painful shoulder. So you would lie with that painful shoulder underneath you, and you would start to rotate the arm down towards the bed or the floor, in order to kind of work on that internal rotation. So that's something that your kind of first contact physios could certainly teach patients, if you've got one working where you are. And then the final thing is people who are working in kind of a physical job, you know, people working in retail, stacking shelves, those kind of things, that kind of repetitive flexion-based activities will probably need amended duties during that painful and frozen stage, because just continuing with those exacerbating activities will probably just make their pain much harder to control and their night pain much worse. So we were going to talk a little bit now about what the current guidelines say for drug management. So I think Desi has another poll ready.
It's in the chat. Now, we appreciate there's a lot of prescribers in here, so I'll tell you now, the evidence is very conflicting. So it's more, let's have a conversation of what you do at present, then obviously if this can change what you do later on. But the key. Right, so for speed, I'm abbreviating. And if other, can you write what your other is? And prescribed if possible. And if you're not a prescriber, obviously, what might you ask a patient to get over the counter? What might you ask the GP? So a lot of, and just to confirm, when we talk about NSAIDs, are we talking ibuprofen or do we go straight to naproxen? Comorbidity dependent. So half of the votes to NSAIDs, so naproxen. Cool, if we go to the next slide. So or cocodamol, not codeine. If pain's bad, combine for 2 to 4 weeks. Give PPI, very good. Yep. So this is what BMJ best practice advise. I believe this was 22. So it says that anti-inflammatories are the mainstay. So starting off with ibuprofen or again, this is where I'm not a prescriber in my pronunciations, meloxicam or naproxen. Now, it says on here, its secondary option is about prednisolone. So I appreciate no one has actually put that down, but saying it orally. I personally haven't actually seen this before. If we go to the next slide, so that's where I said there's a big piece of conflict. So as per the NICE guidelines, NICE guidelines say consider paracetamol as first line with regular dosing, saying that you should have it more regularly as opposed to PRN. Then it's saying if there's no early benefits with non-steroidal anti-inflammatories, then discontinue. So obviously that's a big conflict with BMJ saying you should be using anti-inflammatories, whereas this is saying only if you actually get an initial benefit. And then it's saying here oral steroids are not recommended by the British Elbow and Shoulder Society. So this, and then obviously steroid injection is shown to be more effective. So it's just something to consider in your management, and more than happy to have a conversation. I personally have gone down more the NICE guidelines when recommending, but what do our prescribers think? Is that just a mute off or a contribution? Trial and error sometimes, yep. So this is just more the takeaway from this is what the research is saying and what we wanted to put forward. So we've got some NICE guidelines and we've got trial and error. So it's just be mindful. And yes, comorbidities are always going to play a big factor. So obviously some you're not going to be able to give anti-inflammatories. Should we go to the next slide? So I'll hand over to Laura, but that's where obviously some GPs or some of your first contact physios can do joint injections. So do you want to start off, Laura?
Yeah, so then the second line management is intra-articular injection. So the preferred technique is a glenohumeral joint injection using Kenalog and a local anaesthetic. It just provides that concentrated local treatment of the inflammation, and it can be considered in patients who have ongoing pain, despite having tried those first-line medications and possibly some physiotherapy. So an RCT has found that giving a corticosteroid injection before the start of a physiotherapy program actually provided better results in terms of pain reduction, movement and function, compared with people who were just prescribed oral NSAIDs. But this was only in the short term. So kind of this, the findings of this research project are really consistent with previous studies that show that having a steroid injection and then physiotherapy provide kind of faster results, and that the outcomes are better at 3 months, but at longer term follow-up there isn't really any difference. So I think obviously it's a kind of a patient-led decision here, really based on how much pain they're experiencing and probably what they're required to do in their day-to-day life and for their occupation. So another meta-analysis has shown that multiple injections are beneficial. So each injection lasted on average 16 weeks, with as many as 3 injections having a positive effect. So obviously PGDs vary depending on where you're working, but the PGD that we use here in Nottinghamshire states that as non-prescribers, which predominantly the FCP physiotherapists are, that they can do 3 injections, but then if the pain recurs or that the injections haven't worked, that we then would refer to orthopedics. But yeah, obviously there is good evidence to say that as many as 3 injections can have a positive effect. And then there's also some evidence to suggest that if you inject into the subacromial space, it can be just as effective as injecting into the shoulder joint itself, but with fewer adverse effects. So the concerns about injecting into the joint space are obviously that you're kind of introducing something foreign into the joint. And we know that while steroids are brilliant for short-term pain relief, in the long term it can cause that accelerated osteoarthritic change to the joint. So there is option potentially for somebody who's had lots of shoulder joint injections in the past, or if you've got somebody who has a history of having had shoulder surgery, then there is that option to inject into the subacromial space, and that may be that might possibly reduce your side effects from the injection.
And probably on injections. Sorry.
Oh no, go ahead.
As I say, on injections, it's just making sure, and I think any shoulder pathology, it's making sure it's telling the patient it's in conjunction with the kind of the physio side, because generally, probably frozen shoulder is the only one where it'll help with pain, but it's that whole picture. So when I say selling it to a patient, but when advising them, it's making sure it's just giving us the window to then do the other work.
Yeah, I guess the other thing to say about injection is that it's not really going to help with the stiffness, it's only really going to help with pain. So if you get somebody through and their stiffness and their functional limitation is their main concern, then an injection probably isn't worth it. But in those early phases when the shoulder is very painful, that the injections can be great. And I think with most conditions, we would encourage the patient to give things a little bit more time to try and heal by themselves before we go ahead with the steroid injection. And I think frozen shoulder is probably one of the only conditions that I would kind of endorse or encourage a sooner steroid injection. So if somebody's having, there is evidence to suggest that if you have a steroid injection earlier in that initial painful phase, it can reduce the amount of joint fibrosis. So as well as helping at the time, it can kind of help to limit the stiffness and the functional difficulties, because if you can reduce the inflammation in those early stages, it's thought that you then get less fibrosis and therefore less joint stiffness. So moving on now to interventions that could be referred to in secondary care, so kind of now thinking about third line treatments for your patients who are still struggling despite having had physiotherapy input and up to 3 injections. I'll hand over to Lizzie.
Yeah, so and this is probably the one I see the potentially recommending the hydrodilation is probably your post-stroke frozen shoulders. They're probably the ones that I'm more inclined to send this way if an initial one in primary care is not effective. So like Laura said, a lot of the MSK physios are working under PGDs, and we can't really add volume unless they're prescribers. So the normal shoulder joint can accommodate about 8 to 15 mils of fluid. The frozen shoulder is about 7 mils. And the research is really conflicting. There's no kind of consensus of what hydrodilation volume is. So it ranges from 20 to 90 mils, which obviously is a significant difference. And even recent like systematic reviews and meta-analysis, there's no quality case studies or quality papers to actually have a consensus of what is the best practice in terms of volume, when to do it in the pathway. So in primary care, if we're failing with initial pain relief, and so I would say 2 injections, then refer on, and that's where these decisions can be made. It says that the hydrodilation is less effective if it hasn't got the associated like kind of manipulation alongside. And really hydrodilation is only helpful increasing external range of movement, as opposed to compared to the more non-conservative treatments. So at the end of the day, it's saying to patients like what is the concern. So again, if it's more the range, is it the pain, is it the function, and that's where that subjective really comes in. Yeah, so that anything else on that one, Laura, that I've missed?
I think just to say that another kind of high quality RCT just recently looked at the difference between a glenohumeral joint corticosteroids, a subacromial space corticosteroid, and then hydrodilation in the treatment of adhesive capsulitis. And again, in the short term, it found that the hydrodilation did help to improve pain and range of movement. So at the 1 and 3 month follow-up, those patients that had the hydrodilation seemed to be doing better. But by 6 months, everybody was functioning the same and reported similar pain levels. So it's, I guess with hydrodilation, it's about whether or not that for that sort of short-term improvement, it's worth the potential risks really. And the biggest risk, oh sorry, as Desi said, the biggest risk really is that sometimes a very high volume of fluid is put into the shoulder joint, and that you can get capsular rupture, which obviously then causes, you know, long-term issues beyond when you would expect a frozen shoulder to have repaired.
We've got to factor in, and we'll talk about this really at the end, is what is the climate we're in at the minute. If we're in private care, it's a completely different story, but what is our time frames? So is it by the time you get in front of an orthopod, are they actually in that thawing phase? So with this hydrodilation, it's when is the best time, but also is it reasonable within our provision timeframes at the minute? How quickly can we refer to the interface? How quickly will they assess and refer on? Versus obviously how quickly do we get investigations to rule out other pathologies? So I think that's a big part in these more invasive procedures.
Yeah. So then other options that are available surgically, one is a manipulation under anaesthetic. So essentially the patient's anaesthetised, and then the shoulder is pulled into those end raised positions, which haven't been available to the patient when they've been awake. And you know, it's still a procedure which is in the guidelines, is still recommended for certain groups of patients. It has been shown to sort of free some of those adhesive and fibrotic tissues, and might allow for an improvement in range of movement. There's evidence to suggest that an early manipulation is more effective than a late manipulation. So I think sometimes I definitely am at fault for doing this. I think I hang on to patients in primary care with a frozen shoulder, thinking, you know, it's normal for it to take 18 months to 2 years in order for it to resolve. And I would possibly only refer to orthopedics in somebody who is kind of still really struggling at that 18-month point. But potentially if a patient is you know, struggling at work, struggling with function, struggling with their care and responsibilities at home, and are open to surgical intervention, possibly we should be referring them a bit sooner. A manipulation under anaesthetic isn't suitable for anybody who's had previous shoulder surgery, so kind of those rotator cuff repairs, or they wouldn't be appropriate to have the procedure, just because there's a risk again of trauma, and also anybody that's got poor bone quality, so kind of your osteoporotic, osteopenic patients, there's a risk of fracture with a manipulation under anaesthetic, so it's not advised for that group of people. So very similar to the last kind of high volume injection procedure that we looked at. It seems to be that there's no difference in the long term between patients that have had a manipulation under anaesthetic versus patients who've just received physiotherapy alone. And interestingly, that group of patients, it included patients that had a manipulation under anaesthetic with also an arthroscopic release. So a capsular release done under arthroscopy, I think is probably the most commonly seen surgical procedure in patients with frozen shoulder that hasn't got better. The surgical release can be done in different parts of the capsule, depending on what the patient's biggest issue is. So depending on whether they've lost more internal rotation versus other movement loss, depends on whether they do like a posterior release or a more anterior release. And with the arthroscopic releases of the capsule, there has been some good short-term and long-term benefits reported. Again, the use of arthroscopic release is being considered earlier in the course of the treatment, but the optimal timing of this surgery hasn't yet been defined. So it's difficult to know at what point we should be referring these patients into secondary care. So I think, yeah, it's just got to be kind of that those patient-led shared decision-making discussions. And if somebody's really struggling to manage their activities of daily living, then, you know, there is evidence within the guidelines to say we should be referring for the consideration of these surgical options.
So this is more, oh, sorry. The more NICE guideline points. So if we go to the next slide, everyone will get these slides sent out afterwards.
Do you want me to skip forward again?
Yes, please. Yeah. So we've got the NICE guidelines, but what I put on here is, what does it mean in primary care? Because we know obviously some things that we can't do straight from primary care. So initially, obviously offering analgesia, especially in that early phase, that pain predominant phase. And it might be, it's discussing with your first contact practitioner, pharmacist, A&P, GP, so your prescribers, if they need anything that's not over the counter. Starting with physio as early as possible. So ideally it's getting patients booked straight in with the FCP MSK to be able to educate on the pathology. What is the exercises they can do at home? Are there any other areas that they can work on? And obviously that's where the MSK FCPs can also advise on medication, on analgesia as needed. And then where appropriate, refer on to those secondary care interface or advise on what they could do privately should they wish. Is that consideration of that early injection. So as Laura said, and I agree, kind of this is probably the only shoulder one that I might do earlier rather than later to help with pain. And again, pain has to be the problem. So it's making it really clear to the patient, what is your main concern today? So if you've got FCP or GP that is trained in doing joint injections, but ensuring they've got the other elements alongside, so making sure they've got the rehab to get the most benefit out of the injection. Again, in primary care, probably what our big responsibility is making sure that we're ruling out the other differentials, doing bloods and any other investigation, making sure we're asking those differential questions. That's probably where our big responsibility lies. And then it's referring on to secondary care, so be it your MSK rehab or your MSK interface who would refer on to those secondary care orthopedic services. One thing, again, we need to consider is what are our timeframes. Like I said earlier, it's nice to say in the guidelines that we do X, Y, and Z, but we know with waiting times, it's what is realistic for the patient. Is it we have to refer on earlier because that's going to be their better opportunity? Is it referring to that MSK interface a little bit earlier because they can always investigate as needed? So that's probably frozen shoulder in a nutshell and kind of how it applies to primary care. Can I go for the next slide, please? I'll do a quick roundup. So one thing today, so what we wanted to do is present what is the current evidence on some of these challenging pathologies. So we do have an evidence support services through the Nottinghamshire Training Hub, so they can help with pulling off data. So that's all we did today, is we asked them, we want to look at the evidence for the last 10 years on this pathology. So we can go in the next slide. And that's where here's all the details. There's also how to do literature searching yourself, getting any support if you want to get more evidence, if you're doing projects, anything like this, please use this service. So if you're a Nottinghamshire clinician, they are absolutely brilliant. If you're writing publications, Sarah Thomas, who's one of the librarians at Sherwood Hospital, she can support and again send this kind of information towards you. So what we're hoping to do is another one of kind of the best evidence pathways. So we're aiming to do plantar fasciopathy October, November time. So what we'll do is put it online, but again in a similar format. What is the current evidence? And then making sure we share it and make it primary care specific. And then when you get the slide, you'll see all the references, best practice for diagnosis and treatment. So if we know, next slide. So it's just making sure we've got the Grow Knots app. So all the training courses from clinical to non-clinical go on this app, or you can go on the website. If there's any other topics that you specifically want to go into, so especially for the FCP type roles, that's please either put it in the chat or on the feedback form. That's where we're more than happy to tailor to what you want to know more about. If you're right to stop sharing. So are there any questions? You can go in the chat. Discussion. Any learning points that are going to change today? Paul, are you saying something?
I think just to add a final point, I really wanted to find some definitive evidence on whether or not we need to be x-raying shoulders prior to corticosteroid injections, and I couldn't find any. So I think in conclusion, really, if the shoulder pain seems to really fit with a frozen shoulder, so if it's in the age group that you would be expecting, if they've got the comorbidities that you were expecting, and if the history of the present condition is kind of as you would expect for a frozen shoulder, there's probably no need to investigate before an injection. However, I think it's just those kind of outliers. So in a patient who's young, in a patient who's, you know, otherwise really healthy, if the shoulder has become sort of stiff very quickly without that kind of initial painful phase, you know, maybe they're the ones that we just want to be a bit more cautious and investigate first.
Obviously, and so looking at that history, so I would say anyone with any kind of oncology, I'd probably always just x-ray first to rule out if the first one wasn't effective. So I normally do a follow-up in 2 weeks. If we've not got any improvement, I'd probably x-ray to rule out why not. Is it just that it's not been effective, or is there another pathology? But most of the time, if it's pains, that's the issue, we'll know relatively quickly if it's made a difference. I feel like x-rays is probably the only quick investigation that we can get at the minute in primary care. But obviously it's making it clear to a patient, it's not there to say it's frozen shoulder, it's there to rule out something else. So that's where it's that expectation of the patient that this is not the magic diagnosis, because it doesn't actually confirm that it's frozen shoulder.
Danny, I think you might have a question or a point or something to add.
Yeah, thanks. That was a nice summary of the evidence for things we see a lot of. Certainly, I seem to see a lot of these in my PCN. Whether they are, I don't know. higher chance of getting it. Other comorbidities like diabetes where I work. Yeah, I guess it was a good point about the X-ray, because I tend to X-ray if I think they're going to need a cortisone, CSI. So yeah, I guess that you raise a good point. Do we definitely need to? And do you feel happy to, knowing that your differential and excluding the other things is enough? So that's something to think about. And yeah, I like the evidence. Actually, it seems like really from a surgical perspective, they don't really overall seem to do any better than if you just let the course run and the pain's adequately controlled. Whether that needs to be with, like you say, a cortisone or medication. I do really bear a lot that they just need to ride it out, really. That it's one of those things that out of everything, it is self-limiting, and it's an unusual thing compared to the other conditions, really, that if you can get your pain under control, it will get better majority of the time. So I do stress that.
You're the expert, Danny, but education that this is normal, that it takes time. It's not like it should resolve in a week if I do an exercise. It's knowing that this is a long haul. So I think that's where it's really important. If you're going to do anything as an intervention, actually just explain what it is, send them resources. It's a slow, long slog. And
actually, sometimes once you say they know what it is and they know that it might take 18 months, a lot of people are just like, okay, I can get on with it. You only see the ones that where you, like you say, are just really acutely painful and can't sleep, can't bear it. Then yes, you might need to do something about that. But most are just happy. It's interesting to see also that exercises are back in, as I always give them, but I don't often refer on to further physio, mainly because I know really then the provision is just going to be more exercises in our locality where we work. But like you say, when I first trained, we used to do a lot of manual therapy with these shoulders. And I like you, Laura, still thought that was not as favourable, but it looks like there's a little bit of evidence to say if they can access that, that's worth it for better movement.
It's one of those, is it a desensitisation? Is that what it really is? Is it that, when we're doing rehab, it's not about the shoulder itself, but the other structures around that might be compensating? Is that where we've got more power in this pathology? So it's making that we're not just isolating the capsule itself.
Yeah. For those of you who don't know Danny, she works for the pain service. Do you see many frozen shoulders, Danny, come through to the pain? No. Because they get better.
Yeah, exactly. This is it. Yeah. Well, I don't think, we just don't see them. The only shoulders we really see are maybe really horrendous osteoarthritis that aren't for surgical option. And I've maybe seen someone with a scapular fracture, again, that couldn't be surgically managed. But it's a very, very small proportion. And and certainly no frozen shoulders. I think we have some shoulders that are stiff, but that's another reason. Not true.
Because they've not been moved rather than stiff.
And I think the other thing is that classically frozen shoulder gets overdiagnosed a lot. Certainly, maybe more so than previously than it does now. But if it was painful and didn't move, it used to get called a frozen shoulder. But I think then often people come saying, "Oh, I've had that before," but then you look back and you realise it probably wasn't that. It was probably just some cuff pain. But then they couldn't move it just because the nature of how it seemed to present wasn't that. So sometimes people will call any painful shoulder that doesn't move a frozen shoulder, and it's not actually that. I think it's knowing the true difference in the pathology.
An interesting point in the chat is saying that X-rays are notoriously insensitive to picking up red flags and give a false sense of reassurance. Even blood tests are not particularly sensitive. If you suspect a red flag, refer for an MRI, orthopedics or rheumatology. So I think that's where, when I said at the very beginning, your subjective probably is the most powerful thing, and that to look at the whole picture.